welcome to Transfusion Practitioners Across the World, podcast for TPs and other transfusion professionals to talk all things blood transfusion. Hello and welcome to our podcast, Transfusion Practitioners Around the World. My name is Rachel Moss and I'm an advanced transfusion practitioner at Great Ormond Street Hospital in London. I've been a transfusion practitioner for 22 years and I'm also co-chair of the ISBT Transfusion Practitioner subgroup, working with transfusion practitioners from all over the world. We are very fortunate to bring you this podcast today thanks to the support of ISBT, the International Society of Blood Transfusion. It is a global community of professionals sharing knowledge to enhance transfusion practice, blood management, and it does so by providing opportunities for advancing knowledge and education and by the advocacy of the welfare of donors and patients. ISBT has many working groups that focus on specific topics or areas of practice, and one of those is the Transfusion Practitioner subgroup. If you're not sure what a transfusion practitioner is, go back and listen to our first podcast about what is a transfusion practitioner. So a previous survey of transfusion practitioners we now refer to as TPs, done in 2020 by a group led by Amar and Daisy, this is our ISBT group, showed us that the term TP is an umbrella term. It's for anyone working in a similar role, so transfusion safety officer, transfusion nurse, hemovigilance officer, patient blood management practitioner. We know that a number of countries have this role, and in the United Kingdom it has been established for over 25 years. However, we know not all countries have introduced this TP role. So today I'm talking to Lawrance Nyoni, who works as a TP in London, but he's originally from Africa, Zimbabwe, and what we want to talk about today is how the TP role might work. So hello Lawrence, please tell us about yourself, your experiences, and how you came to be a TP in London.
Thank you, Rachel. I'm delighted to join you today to discuss this important topic. Yes, I'm originally from Zimbabwe and I've been working as a transfusion practitioner in London for close to 5 years now. So after graduating in Zimbabwe as a biomedical scientist, I worked there in South Africa for about 6 years before I moved to the UK in 2010, where I continued to work as a BMS. And at the peak of COVID, I made the decision to join the transfusion world, transfusion practitioners world. And there's been quite an experience, and I'm looking forward to sharing my experiences in both working on the African continent and here in the UK.
Delighted that you're here with us. And I just want to say at this point that the discussions that Lawrence and I are having are very much about our world, our experiences, our sort of thoughts. So I just want to make that clear. This is Lawrence and I and our conversation. So, Lawrence, tell our listeners about blood services in Africa. And you know, there will be some key differences between there and the UK.
Absolutely, absolutely. You know, as you can imagine, a continent of 54 countries, the landscape of blood transfusion in Africa is quite complex, you know, and varies significantly across the continent. But I'll start with our donation systems and blood availability. So, for example, we know in the UK and most of the Western world, there are well-established voluntary non-remunerated blood donation systems, which is the majority of blood donations coming from voluntary donors. In Africa, there is a mix. So we have a mix of voluntary non-remunerated blood donation systems, and we also have what we call family replacement donation systems. So now these are systems where if you were to get a blood transfusion, you would then have to arrange for a replacement for the blood that you'll be receiving. The numbers do show that, you know, in Africa the volumes that we collect are quite low. So just to give you an idea, if you look at the WHO Global Status Report, I think the latest was 2021. At this time, Africa, which accounts for about 14% of the global population, contributes only about 5% of your global blood donations, which is about 6 million whole blood donations. So it does give you a picture there. If you look at the donation rate, your median donation rate at Africa, looking at something like 5.4 per 1,000 population, versus in European countries, we're looking at something about 30 to 32 per 1,000. So it does show you that Africa is one of the undersupplied regions in terms of blood in the world. And again, the cost of producing a unit is also quite high. There's a paper from 2016 which looking at the cost of producing 1 unit of blood in Zimbabwe, and it was approximately about 131 US dollars, which is about 8 to 10% of the country's annual GDP per capita. If you compare to a country like UK, it's about 0.35%. GDP per capita, to produce a unit. And again, so if you look at the context, in Zimbabwe, an average salary might be around $270. So imagine a patient requiring up to 3 units of blood, in a private facility. The cost can get high very quickly. If you look at the infrastructure, again, we see differences there. We know, in the UK, NHSPT, it's got to know all the, latest equipment or comprehensive laboratory testing systems in place, etc. Again, the story is different in Africa. You have on one end other countries which are quite comparable to the developed world, and then of course you've got the other side where there are challenges. We still have challenges in transfusion transmissible infections. As you can imagine, with the high a prevalence of some of these across much of Africa, it creates that burden on your testing. If you factor in the window period, and some of the testing technology might not be the best out there. So even if you to do universal screening coming from that high residual risk, if you factor in that, so it does create challenges, which is where we need the most advanced technology on the continent. Clinical indications, again, we see differences there. If you look at the numbers, the majority of the blood in high-income countries, they are consumed by your 60 plus age group. That's for your surgical procedures, cancer treatment, hematology conditions, etc. In Africa, quite the opposite. The majority is used to keep young children alive from severe anemia as a result of a disease such as malaria, and also from preventing women from dying during childbirth. So again, it shows you the differences, but we do have success stories, of course. Rwanda, for example, they have an innovative drone delivery of blood to remote areas. We've got success stories coming out of Kenya, where they've recently achieved, their SMLTA, a strengthened laboratory management towards accreditation standard. And of course, we have South Africa and Namibia, who also operate some of the most sophisticated blood services on the African continent. So I would say, as a transfusion practitioner, this is where we would really make an impact. Many of these challenges are exactly what TPs in the UK and around the world are trained to address. So yes, looking forward to that.
So, are there any TP roles in Africa?
Not as you would describe it as a TP, but when I was doing some research to prepare for this podcast, I've seen variations of what would describe as a TP. So, for example, in Namibia, they have a medical officer who does something or some of the roles that would traditionally be done by a TP. So the medical officer, for example, in Namibia, manages quite an extensive portfolio. They sit at the National Blood Services and they oversee the transfusion activities across the entire country. So they do your data analysis, your traceability, your audits, training, and they're also involved in hemovigilance. So, and they also provide clinical advice, instances such as transfusion reactions, for example. And recently, Namibia was in the news when they performed their first autologous stem cell transplant, and the medical officer played the pivotal role in the coordination of bringing that service online. And of course, South Africa has a similar model of a medical team with oversight. But these roles is the medical team sits at the National Blood Services, and I think that's it becomes debatable then whether is this a traditional TP role. To me, these are often senior clinicians sitting at the strategic level, which is important, but it's not quite what we need. So, what I think we need is champions at the operational level. So we need champions at the operational level. Staff would answer your day-to-day queries. Attend your major hemorrhage episodes in real time, provide that support in real time, your education, so these are staff, who are on the ground, as opposed to the centralized model where we might have a medic just sitting in the National Blood Service in charge remotely. I know we're chatting to Namibia, they have transfusion contacts. So these are, but again, they have their day-to-day jobs. So this becomes kind of an additional responsibility. So, and I think what we've done it in the past. If you look at the success of how we managed to tackle some of your malaria and tuberculosis, the way what we known as diagnostic microscopists. So these are individuals, just trained to diagnose be it parasitic infections like malaria or, or tuberculosis at a rural district level. So this often common in areas where it is challenging to recruit your qualified biomedical scientists. So you then find these local champions trained specifically for diagnostic microscopy. So I believe a similar model could be adopted for transfusion, where you might have transfusion champions who can give that required support, might be nursing or laboratory background or even pharmacy, for example, and then we train them in aspects of transfusion medicine. And then once you have those in place, and then you might then have kind of some reporting structure, which might then go up to your either your provincial or city level, and then up ultimately up to the national level, where those senior clinicians and medical specialists provide oversight. And I believe that approach might be what we need in Africa.
So, as you know, ISBT, we want to promote transfusion practitioners all around the world, which is the name of the podcast. So, I'm going to give you the chance to be the first TP scientist where you trained. What sort of things would you do?
Where do I start, Rachel? It's something that I find deeply exciting when I think about, and obviously as a transfusion practitioner, I know the power that we might have in this context. So if I was to get that role, my starting point would be education and training. I think that is the backbone of a functional, system. So there is a shortage of personnel trained in transfusion medicine across much of Africa, and ensuring that we have appropriate required levels of education and engagement will allow us, to be able to drive, that patient blood management strategy. And it's something that I think we also want to focus on, conscientizing, your teams, your hematologists, your surgeons, anesthetists, lab staff, etc., on what is patient blood management, why is it important, and of course, setting up your transfusion committees, making sure that they deliver on your PPM principles, your audits, measuring outcomes, monitoring the appropriate usage of blood, you know, and I think that's where we also, I think majority of our wastage is coming from blood which is discarded for as a result of TTIs. So again, so trying to strengthen our testing capacity so that we reduce that wastage will be one of my targets. And of course, to integrate the whole primary healthcare team. So, because most of these we want to manage, as you are aware, PPM, to make sure that the anemia is managed well to reduce the need to have a transfusion in the first place. I mean, if it means working with your infectious disease partners, to preventive strategies to avoid that exposure to those, malaria parasites, your hookworm, etc., etc. So I believe that would be, and of course, the main one, again, is your regulatory compliance, and your governance structures to make sure that we have functional systems, in place. And there's a starting point, I know the WHO has produced standards, your Africa Society for Blood Transfusion does have also your benchmarking standards that we can start from. So I believe, yes, that would be an exciting journey, Rachel, if you had to give me that job.
It sounds it. And interestingly, kind of where we were 20 years ago. So you're doing the same sort of things. It doesn't matter where you are. You mentioned then the African Society for Blood Transfusion, and we know that the ASBT and the ISBT had a patient blood management education day in Kampala in 2024, and you've told me about that. But please do share your experiences of that.
Yeah, thank you, Rachel. No, it was an interesting one, Kampala, Uganda, in March 2024. So the first day was an ISBT Academy Day, which was dedicated to patient blood management. Full day of just interactive, workshops, presentations, and I think the focus there, was about how do we then looking at our three pillars of PPM, but with a special focus on how we can implement these in a low to medium income country setting, which is what we need in most of Africa. It was a very engaging session. Went into our groups, looked at the practical strategies to implement PPM in a resource limited setting. What are the specific barriers and challenges that we face in Africa, and what could, the actual impact of PPM on your healthcare delivery in our different contexts. And it was good to see that energy, the sharing of ideas in the room, different countries, different professions, from your laboratory managers, your clinicians, your administrators, all coming together, to share that. And I think it's something that we really need. And I am looking forward to the next Congress, which is happening in Namibia next month, March 2026.
Excellent. We look forward to hearing about that. Well, we will in our group. So, as we know, haemovigilance is a real crucial part of the TP role. It's where we really started, and certainly in the United Kingdom, our excellent serious hazards of transfusion haemovigilance system is a massive part of what we do. Are there any haemovigilance systems in any of the African countries that you know of?
Yes, so when I was looking at the numbers again, the WHO Global Status Report does report that 40% of countries in the whole Africa region did report having hemovigilance systems. And I know there was a recent survey that was done by the AFSBT, and when I spoke to the managing director, they told me that they will be presenting the numbers at the coming Congress. So looking forward to see if there's been a shift. So from this was a 2021 report. But again, I think the challenge again that we have sometimes is systems are in place, but are they functional? Are they well-resourced systems? Becomes quite different things, which is what the authors of a 2021 study on implementation and performance of hemovigilance systems in 10 sub-Saharan African countries concluded. So, and again, I think this is the theme that we see across. And I think what my argument is, rather than saying we have a hemovigilance system in place, I think we need to build the foundation first. So establishing the foundation first, ensuring accurate documentation as part of your business as usual, ensuring that all your activities, are documented, your traceability, donor to recipient, making sure we have incident reporting systems in place, developing that culture of learning and improvement, where reporting is not seen as punitive, but more of an opportunity to identify your system weaknesses and preventing future incidents. And I think this is where the transfusion champions that I discussed earlier would come in and help provide that day-to-day operational support, helping staff document properly, ensuring your traceability, incident investigation, and helping build that culture of continuous improvement. And I think once we have all that in place, it's very easy for hemovigilance systems to evolve naturally as the infrastructure matures. I think that progression from basic documentation, incident reporting to more sophisticated surveillance and analysis systems will just become organic, and I think there is hope ahead.
Oh, I love this. It's so interesting. Anyway, finally, please sum up for us about being a TP in the UK, coming with your experiences of Africa, and just how you enjoy your role here.
No, it's a very diverse role, Rachel, as you know, and nothing would have prepared me for this. And I guess that's the beauty of being a TP. One day you're a project manager managing the implementation of hemobank blood fridges across the hospital. The next day, subject matter expert providing that support on an electronic health record software upgrade. Next day, you're a data analyst drilling down on those transfusion trends and audit results. And another day, we are teaching medical doctors about safety, in transfusion practice. It's quite varied. And of course, we have our London catch-up face-to-face meetings, and that pint afterwards. I guess for me, it's the knowledge exchange that keeps me energized, learning from senior colleagues like yourself, hearing about challenges faced by colleagues from other hospitals, seeing how the role is evolving, not just in the UK, but across the world, and knowing that I'm at the forefront of implementing such an important role is genuinely exciting. And it is my hope that I'll be here to witness the implementation of this role, Rachel, in Africa. And who knows, maybe I'll be the first TP with a biomedical scientist background working on the African continent.
Oh, don't forget the rest of us when you get there. We'll come out and talk at your conferences. Lawrance, thank you so much. I think the reason I've been so excited about this podcast is it embodies everything that we're excited about. First of all, the TP role, and everybody that knows me will know I can talk about this for hours, but bringing experiences from other countries, bringing it under the ISBT umbrella, that's what this is about. So thank you so much for your time, for your amazing insights, and for just talking to us today. And yeah, I can't wait till you're the first TP in the African states. So thank you to our listeners. We really appreciate your time. If you have any feedback, please use the questions linked to the podcast. Any further questions, you can visit us on the ISBT website. Check out the Clinical Transfusion Working Party and the resources on there, and of course the Transfusion Practitioner subgroup pages. We look forward to having you on our next episode, and we've got plenty more things to discuss about the transfusion practitioner role. So until then, thank you very, very much for listening.